Welcome to New Retina Radio, and this series is called Vitreous Opacities. I'm John Kitchens with Retina Associates of Kentucky. On this debut episode of Vitreous Opacities, we will explore how surgical innovations have improved our ability to address vitreous opacities with our patients, and how these innovations may affect our decision on when to take the patient to surgery. On this episode, I'm going to be joined by two guests. We have Dr. Christina Weng from the Baylor College of Medicine.
John, thanks for having me.
Absolutely. And we have Steve Houston from the Florida Retina Institute.
Thanks for having me, John. Looking forward to the great discussion.
So kicking things off here, really, you all are I want to say newcomers to retina, but you all recently graduated from fellowships and have been out in the last 5 or 6 years. Steve in 2015, Christina in 2014. Have you seen, Steve, a change in the attitudes towards vitreous opacities just since you finished your fellowship?
I think I was a little lucky that where I trained, we did some of these cases, so it wasn't quite, kind of that voodoo of not doing photorectomies at this point. So vitrectomy for vitreous opacities was, somewhat accepted, and so I saw that some of these patients could be helped really well, and were very happy after these surgeries. So I took that into practice and really initially was a little cautious at first, but I feel like I've definitely progressed more now over the past few years.
And Christina, you're in an academic setting, Baylor College of Medicine. One would think that an academic setting wouldn't necessarily be the type of place that you would do vitreous opacity surgery. So kind of tell me how you've worked that into an academic role.
Yeah, absolutely, John. It's interesting to think about how stigmatized in a way vitrectomy for vitreous opacities still is. And, to the question that you asked, Steve, I do think there's been subtle shifts over the past 10 years, but I think it's been slower than I would imagine, especially with all of the advances in our technology and instrumentation that we've made. So, I think it's the culture is very regional, it's very institution dependent. And you're right that at a lot of academic centers, doing vitrectomy for vitreous opacities has not been really that well received or done commonly. But to me, and I think we would all agree, it's one of the most common, if not the most common complaint that we face every day from our patients. It really does impact their quality of life. And so to me, performing a treatment for a significant and symptomatic condition, it's really no different to me than doing that for an epiretinal membrane or a macular hole.
I agree with you, Christina. I mean, these are really, truly some of the happiest patients. And the dogma used to be, you don't operate on a 20/20 eye. Steve, where do you think that changed? Where did we jump over from being surgeons that were just focused on fixing maybe potentially blinding conditions to actually some of these more quality of life conditions?
I mean, I think, our anterior segment colleagues probably led a lot of this where, we were early on doing surgery for, corrective LASIK surgery, PRK, now, a lot of clear lens exchanges even, and then starting to get into a lot of the premium IOLs. Patients really have high standards for their vision these days, and the anterior segment colleagues have really pushed that envelope in what they can offer for patients. So I've seen that where some of these patients that have premium IOLs, especially say multifocals, that would come in and be extremely unhappy afterwards. And oftentimes it's because of the complaints of, diffuse haze and just kind of cloudy vision. And then you do a vitrectomy for their vitreous opacities, and they come back and they're like, man, now I see why I paid for these lenses, and you've really helped me get the most out of them. So, I think that's where I saw it is, a lot of these cataract refractive patients really wanting the best outcomes for them, and seeing that I could offer them that where, sometimes they wouldn't have the greatest outcomes just from the lens itself, and they needed this extra step to get them to that point.
So Steve, you mentioned premium IOLs, and I agree completely. It seems like those patients are the ones who maybe have a greater demand for vision, but is there something about a premium IOL that makes these floaters more noxious for these patients?
Yeah, I mean, that's a great question. I mean, as we've been looking through some of our data, there's a large percentage of our patients that that end up going to vitrectomy for vitreous opacities that are multifocal IOL patients. So not just anecdotally, we're actually seeing that there's definitely a large percentage of our series. Question is why? I think, some of these multifocal patients, with the lens, having the different focal planes, I feel like they're much more, it's much more problematic when you throw in a vitreous haze into the situation. So often, like when have membrane peeling under a multifocal, how you just can never get that quite clear view? I feel like for them, it's the same way. They're getting the multifocal planes where they can see at different distances, but it's probably just never quite 100% crisp at each one. But then you throw in the vitreous haze or vitreous opacities to it, I feel like that degrades it just that extra amount that they really have so much more difficulty. And whether the different different focal planes focus on the different levels of the vitreous as well, of those opacities, I think there's probably some component to that as well. But I don't know if we know specifically, but I think also contrast sensitivity comes into effect as well. So I think there's probably some decrease in contrast sensitivity with these multifocal IOLs, and then throw that in with the vitreous opacities, and we probably have a perfect storm of why we're seeing such a increase in multifocal patients wanting to have their floaters or their vitrectomy for vitreous opacities.
Christina, you mentioned innovations, and I think innovation's been key to this. What are the kinds of innovations that we've had surgically as retina specialists that have really helped kind of facilitate this move towards removing vitreous opacities?
Yeah, well, I think it really affects primarily three areas, John. The first would be visualization. We have wide angle viewing systems now that let us see clearly out to the periphery, an area that is very important when you're considering vitrectomy for symptomatic vitreous opacities. We have wide angle illumination that allow us to see, all the details that we need to see in removing that vitreous. And then secondly, optimized fluidics in our vitrectomy platforms, IOP control, higher cut rates. We're up to 20,000 cut rates now, which of course minimizes the traction. Again, one of the big risks that used to be associated with vitrectomy for floaters. And then finally, in the third area, it would be instrumentation. We now are at 27 gauge instrumentation. And even our 25 gauge, which I commonly use for floaters or vitreous opacities, these smaller gauge instruments allow us to very efficiently, but more safely remove those vitreous opacities for our patients.
Really well stated. You mentioned safety in there, Christina. Is removing vitreous opacities, is vitrectomy for that a safe surgery for patients?
Well, we need more data in this area, John, but I think overall, if you look at the literature, over this past 20 years, with the emergence of these smaller gauge instruments that we're now using, I would say that the trend is definitely significantly shifted into a more safe realm. Now, I know we're going to talk about the nuances in a little bit. It really depends on per patient, what those patients' specific risk factors might be. But I would say overall, with, really efficient instruments, smaller gauge instruments, and efficient instruments that allow us to spend less time in the eye, these all point to a more safe procedure.
So Steve, Christina brings up a great point, is the nuances around this. And many of our battles in surgery are won and lost with our decision-making in clinic before we ever get in the operating room. Is this true for vitreous opacity patients? And what are some of the absolutes that you like to hear, or things that you will maybe not do a patient or wait on a patient in clinic?
I mean, I think that ultimately, these are some of the ones that I really spend a lot of time diving into their complaints. I think it's very important because sometimes, I think we've talked about in the past that sometimes the objective findings are, maybe they're a little bit in some patients, not there as much in others. And then some patients that aren't even symptomatic or have, significant debris and opacities in there that have no problem. So I found that the objective markers are a little lacking in trying to decide, on who to operate on. I think that's one area maybe for further research and development of imaging and other things. But when it comes to in my clinic, it's really a history taking kind of ordeal where I'm talking to the patient, really narrowing down what exactly they're bothered by. Common complaints will be cloudy vision, feel like there's kind of a haze or Vaseline over their vision. Some talk about discrete floaters, but I feel like most of discrete, floaters, opacities, but I feel like a lot of them these days, it's really just that diffuse haze to the vision that they're talking about. And so once I kind of nail down and really feel like, that's really the vitreous that's causing the issues, then I'll definitely look and see objectively, do I see that there's a significant white ring, other opacities? Do I see that there's just a diffuse haze to the vitreous? I use the infrared on the OCT to see, if there's blockage on that image as well. So I think there's a couple ways that we can look subjectively and talk to the patient about it, and then look at some objective markers. But ultimately, I still weigh the subjective markers more in making that final decision, because ultimately it's the patient having a significant issue that I want to address and see if I can. Some things I look for, I tend to be really strict in criteria. I tend to really mostly do pseudophakic patients, but obviously in Florida, most patients are pseudophakic coming to me with these issues. I like to have, them to already have a PVD as well. And then I like to have the capsule already open, or I usually open it during surgery. So those are kind of my initial criteria. And with that, we've looked at our numbers in our practice of probably about 500 plus patients, and we're getting this series together right now. And the complications are extremely low with modern small gauge surgery, to the point where our retinal detachment risk rate is less than 0.5%, and without any other major type of complication. So I think with the right selection of patients, modern surgical equipment like Christina talked about, 25, 27 gauge with 20,000 cuts, 10 to 20,000 cuts, I think we've really made it into a very safe procedure, but in a right patient selection that we have to determine.
Christina, what are your absolutes when it comes to selecting a patient that's a good candidate for this?
I'm a little bit less strict than Steve. I definitely think that it is an advantage to have someone who's already pseudophakic, who already has a PVD. But I find that not all of our patients here are pseudophakic the way they are in Florida. And so sometimes I will make the decision to operate on someone, even if they still have their natural lens, even if they don't have a full PVD. To me, I'm really looking for two things. I'm looking for severity of symptoms. How much does it impact their activities of daily living and in the hobbies and activities that they enjoy in their life? And I'm looking for persistence of symptoms. And so I like to at least watch that patient, have an established relationship with that patient for approximately 6 months before we revisit the option of surgery, although I'll bring that option to them even at their initial visit, because oftentimes these patients are so bothered. But the reason I do that, John, is because we know that a lot of these patients who do have a PVD or symptomatic vitreous opacities, those types of symptoms will diminish or completely go away with neuroadaptation over time. And so I really like to make sure, again, to Steve's point about really picking that ideal patient, I want to make sure we're operating on a patient who really needs that surgery.
So Christina, just to be clear, do you wait until the patient's had floaters for 6 months, or until the patient's actually been able to follow up with you for 6 months?
Yeah, I personally like to follow with them. And I know some people may disagree. They may say, oh, it's just 6 months total in terms of their symptoms. The problem is it's hard to rely on someone's history, first of all. So I really count kind of day zero as that point when they're sitting in the chair in my office and we're really discussing all of these options and putting them on the line. And then from then I'll usually say, let's see you back in 6 months. If you're still that symptomatic, we will further discuss the option of surgery.
Yeah, I think waiting 6 months is definitely important to make sure that it's not just an acute PVD that then the symptoms are going to improve in most of those patients. However, I will say that with my practice patterns around here, I have a lot of optometrists and ophthalmologists that know that we do a large amount of these vitrectomy for vitreous opacities cases. So I often now have a lot of the primary eye care providers monitoring the acute PVD and then sending to me once they've had symptoms for a few months. And so when they show up to my office and they've been referred over from some of these physicians, that I will actually, look and see and talk to the patient about how long they've had the symptoms, but then, I will also look back and see if they were referred over for vitrectomy. And in those cases, they've already been waited out. So I won't hesitate in some of those patients to sign them up for surgery on that initial visit.
Yeah, I think that's a great point, especially with that, knowledge base of your referring doctors kind of identifying what you like. And I tell our referring doctors, look, in general, I like for the patients to be bothered. And I mean, in a significant way, activities of daily living, they have to be affected the majority of the time. I like them to be pseudophakic. I just don't love causing a cataract. And here in Kentucky, we can find great cataract surgeons to take cataracts out easily. And I basically like for the floaters to be there for 6 months. I also am very hesitant to do vitreous opacity removal on patients who have lattice degeneration or have a history of a detachment in their fellow eye. Are there any warning signs, Christina, that we should be watching for before we think about signing up one of these types of patients?
Yeah, of course. I mean, every patient is going to be an individual risk benefit assessment. And that's with anything we do, but particularly in an elective surgery like this, where oftentimes these are high stakes patients. They're often starting out at 20/20, even though they are visually symptomatic. And so you're right. If a patient has a history of high myopia, the patient has a history of lattice degeneration, retinal tears, retinal detachments, even in the other eye, those are not necessarily deal breakers for me, but it definitely ups the ante, if you will. When I have that discussion with the patient, I'll let them know that they are at higher risk for a complication such as a retinal tear or retinal detachment happening. And they have to weigh that in their decision making. But this is really a surgery where shared decision making needs to be and play an active role, because you've got to have that patient fully understand what they're signing up for and really understand the risks, even though they are low, as Steve alluded to earlier.
Steve, let's talk about this one specific scenario that I've run into probably 10 or 15 times, and that's the patient that has an epiretinal membrane, but is asymptomatic with good visual acuity, asymptomatic with regards to the epiretinal membrane, but has bothersome vitreous opacities. Vision's good. Do we take that epiretinal membrane out or do we watch it?
Great question, because I just did one of these this morning. But I tend to, that's where when I talk to them and get a history, I tease out what the symptoms are. The lady this morning was 20/25, had a little ERM with a cyst, but no metamorphopsia, no real central blurriness, just the diffuse haze and vitreous opacities. And I talk to these patients and say, you know what? It's a very quick, straightforward procedure, 6 to 8 minute vitrectomy for your vitreous opacities. You have a little epiretinal membrane, discuss it, say, I don't feel like you really have much symptoms from it. We're not going to touch it on this, but there's always a chance it could progress and we can come back in and do this again and remove it. But, often 2020, 2025, 2030, if they have an ERM, I'm just not that excited to peel, just adding another element of, potential issues that could come up.
Steve, I think you mentioned something very important, and that is talking to the patient about the epiretinal membrane. They're not going to be disappointed if you have the discussion ahead of time and they end up being in that, in my experience, 10 to 15% of patients that the epiretinal membrane progresses in, and we have to remove it so long as you've had that discussion beforehand. Christina, what needs to happen to have greater adoption of surgical removal of vitreous opacities for retina specialists?
I think really twofold. The first is that you'll notice when we have these conversations, there's a lot of diversity and variety in how we even approach the surgery. And so I think there needs to be more study done formally so that we can identify best practices. Should we be lifting the hyaloid every time? Should we, minimize it and only allow patients who have a PVD to undergo procedures like this? We need more discussion and investigation in that area, and also continued innovation. Our instruments, as they get safer and safer, and I'm sure that there will be continued advances in our area. And as this surgery becomes more safe, that risk-benefit assessment is going to continue to shift, allowing us to treat even more patients than probably what we are now. And then the second thing that I really liked about what Steve mentioned earlier is we really need this improved community awareness. We need patients educated that there are different options and what the risks of different options are, because they see a lot of things online, some of which may not be true. And we also need a collaborative approach. I really like how Steve has arranged that situation in his area, where the optometrist that he's partnered with can also be following these patients and know what types of patients he would be willing to offer this surgery to. So, lastly, we need to really destigmatize this type of procedure for symptomatic vitreous opacities. It's a real condition. It truly impacts patients' lives on a daily basis. And now that we have the technology to be able to address it in such a successful and generally very safe way, I think it's time that we continue this discussion and expand it further within our own community.
And last question for you, Steve. You're talking to a surgeon now that's listening, that's never done vitrectomy for vitreous opacities. What would be some pearls of advice if they're thinking about getting into doing this?
Yeah, I mean, not to beat a dead horse with the criteria that I use, but that's an easy first place to start, is to find, have patients that, are symptomatic and, bothered significantly, as we've talked about, and, affecting daily living and all those, factors. But taking, the low-hanging fruit at first, making sure, don't go out and do a phakic non-PVD floater patient, first, because, what's going to happen if they have a complication, RD or something, you're going to quickly say, man, why am I doing these? That was, not the best idea. But you take that pseudophakic with a PVD and you start to identify those patients and start those as your first cases, you're going to get more and more comfortable and see that, it's a safe procedure. You're going to get used to what you need to do. You're going to tease out, the patients that, really are affected significantly and then come back and are extremely happy afterwards. I would say they're some of our happiest patients that we see these days. And really trying to point them in the right, the surgeons in the right direction of saying, let's walk before we run in this, so that you don't get over your head and start to have, more complications from more, borderline type of cases, and start with the low hanging fruit in that respect. And then, really just focus on the technology. We've got, the small gauge instrumentation, 25, 27 gauge in 10 to 20,000 cut rates, small incisions. Make sure you've got your technique down. It should be a very quick procedure. Don't spend a lot of time in the eye. Get in what you need to do, core vitrectomy, shave a little bit up the periphery, and then be done. Make sure to always scleral depress and check the periphery. That's one of the most important steps. I would say I tell anybody observing with me, or anyone I talk to about this, I feel like that's probably the number one most important step of this procedure. We're all used to doing the vitrectomy parts, but this is the one where you don't want to miss a tear, because it's easily avoidable. And I'd say if there's a suspicious area, don't hesitate to laser it. Obviously any lattice, things like that, I would often laser, but scleral depress, make sure you have good viewing of the periphery, and, make sure you set yourself up for success.
Well, that's it for this episode of Vitreous Opacities. I would like to give a special thank you to our panelists, Christina Weng and Steve Houston. Be sure to subscribe to New Retina Radio on whatever podcast platform you use. We'll have more from this series coming in the near future. For now, I'm John Kitchens. Thanks for listening.